Hello, friends. Today we'll be talking about a very interesting topic, that's occlusion. Now, we'll be discussing this topic because it's a very important topic in a series of videos which I will be posting in the coming weeks. So, what do you mean by occlusion? Occlusion, in very simple term, means contact of teeth. And if we see the role of occlusion in dentistry, now if you see in dentistry, there are three things. Entire dentistry revolves around three things, that is, move, remove, or replace or repair. Now, movement is basically involving movement of teeth. Say orthodontists deal with that. Removal of enamel, dentine, removal of tissues, removal of bone, removal of tooth. All this is involved, and then we replace it with bone grafts, with restorative material, with porcelain, with dentures, that's acrylic. So there are variety of materials, and this all is entirely dentistry. And if we see, neither of this will be possible if you don't consider occlusion. So occlusion has a very important role to play in dentistry as such. So let us understand this topic because it's a very important part of the somatognathic system. Now, somatognathic system or the masticatory system comprises of three components. One is the teeth, the periodontium, and the articulatory system. Now, majorly when we practice dentistry, when we are taught about dentistry, we majorly focus on teeth and the periodontium, but we usually do not concentrate upon the articulatory system, although it is the very important component of somatognathic system. So what is teeth? Teeth is basically involving the dentine, the enamel, and the pulp. So various aspects of dentine, various aspects of enamel, and the pulp, where we talk about the endodontics, the conservative dentistry, all this involves teeth. And next we have the periodontium. And what is this periodontium? Periodontium involves the bone, very important component, gingiva, the periodontal membrane. So all this is part of the periodontium. And the most important system which I was talking about is the articulatory system. So it has three components, that is the temporomandibular joint, the muscles, and the occlusion. Now the temporomandibular joint can be, we can compare it with hinges. It is part of the hinges, muscles to motors, and basically these and occlusion to contacts. Now neither of them will function properly if there is problem or interference in any of the one. And most of the times it is the occlusal interference which causes problems in the temporomandibular joint and the pain in the muscles. So what can happen if you have problem in occlusion? So if you have interferences, or if you are given a restorative material which is having interference in occlusion, or occlusion is not proper, then the patient can have temporomandibular joint disorders, which can basically have negative influence on the craniosacral mechanism, and there can be poor posture, mind you. Because of problem in this occlusion, the patient can also have the problem in the posture. That means the patient can have poor posture, there can be excessive earwax, there can be speech problem, and there can be prolapse of the lumbar disc, all because of occlusion, which we can never imagine. So what occlusion interferences can cause. So these are all the problems which can happen because of this. And if we have a better understanding of occlusion, we can definitely avoid and treat such patients which are having such problems. So moving on further, what is types of occlusion? There are majorly two types of occlusion. One is static occlusion, another one is the dynamic occlusion. Static occlusion is, as the name suggests, that it is the simple contact between the maxillary teeth and the mandibular teeth in a single contact, or this in stationary. So and dynamic contact is basically when the contact happens between the maxilla and the mandible, when there is a movement of the mandible over the maxillary teeth. So that gives you the dynamic occlusion. Dynamic occlusion, or better put it as articulation. Now each is, let us study them. Now majorly when we study about the static occlusion, we talk about the centric occlusion, we talk about centric relation, and we talk about freedom in centric relation. So let us understand each of this. What is centric occlusion? Centric occlusion is basically maximum intercuspation position. Now maximum intercuspation, or you can call this as the bite of convenience or the habitual bite of the patient. So you have a centric occlusion whenever the patient will always be wanting to close. Whenever he wants to close, he'll be coming to the maximum intercuspation position, or the or what we call as the habitual bite. So that would be the most comfortable position for the patient, that he will be biting and coming to this position. And what is centric relation? Centric relation is basically a bone-to-bone relationship. That is, it is a conceptual relationship between the maxilla and the mandible. So if we want to understand centric relation, there are three different ways in which we can understand. That is, we can understand that anatomically, conceptually, and geometrically. So if we see anatomically, centric relation is basically the position of the mandible to the maxilla with the intra-articular disc, which is this, in place, and when the head of the condyle, this is the head of the condyle, which is lying against the most superior part of the distal inclines of the glenoid fossa. So anatomically, if we see, this is the position of the head of the condyle and in relation to the intra-articular disc, and which is in relation to the glenoid fossa. So intra-articular disc, we all know it is can also be called as meniscus. It is having the posterior part of the meniscus and the anterior part of the meniscus and the intermediate zone, which is thin, but this is one of the most important part of the joint, because this is the load bearing area for the joint. So the position of the head of the condyle is superior anterior, and we can call this as uppermost and the foremost position. Some clinician put it as the uppermost and midmost position, although it is really in this superior aspect of this. So we should say that it is the superior anterior position of the condyle, which is most acceptable as of now. Conceptually, is if you see that it is the position of the mandible relative to the maxilla with the intra-articular disc in place. And geometrically, if we see again, it is the position in which the condyles lie in the terminal hinge axis position. Now, what is terminal hinge axis position? So we all know that there are two types of movement as the patient opens the jaw. First is the rotation of the condyles, and then there is translation of the condyle. So when initially when the patient is just opening slightly, there is rotation of the condyle. The condyles rotate around its axis. So this axis, which is the terminal position where the condyle of the mandible is resting, that is the terminal position. So if we see, if we see, there is this is the terminal position of the condyle, and if we join it with the other part of the temporomandibular joint, then we can make an axis that is known as the terminal hinge axis position. So this is when the condyles are in the terminal hinge axis, that gives the proper position of the condyles in relation to the glenoid fossa, and that we call that as the centric relation position. So why so much of importance to centric relation? Centric relation, why? Because it is repeatable position, one, it is recordable position, and it is a skeletal position. It is a bone to bone relationship. So that is the reason why centric relation is so important, because if you don't have teeth, then possibly you cannot have maximum intercuspation or centric occlusion, but the patient will always have the centric relation position, because that's the bone to bone relationship. So, and that is the reason why we attach so much of importance to centric relation. Next is the freedom in centric. Now, what do you mean by freedom in centric? Sometimes it is also called as long centric, although freedom in centric is the most appropriate term. So what is freedom in centric? Freedom in centric basically moves when the mandible is able to move anteriorly for a short distance in the same horizontal and sagittal plane. So this is the movement, as you can understand, that when the patient is moving the jaw from centric relation position to centric occlusion or the maximum intercuspation, that anterior movement, that anterior shift, in order to bring it into occlusion, that is known as freedom in centric. So this is, if you see in the anterior region, this slide, as the patient is moving the jaw like this, then the patient is going to have contact here. So this anterior movement is known as freedom in centric. Now sometimes there will be situation where the patient will not be having any freedom in centric, like in situations which is, say, class 2 div 2. So in angles class 2 division 2, there lacks freedom in centric, and also when the anterior crowns are positioned in such a way that the palatal surface is too thick. So if you make crowns or your restorations which are very thick here in the palate region, so whenever the patient is biting, then there will be no freedom in centric, there will be no movement in centric. So this is not healthy for the joint as well as the teeth. Next, what is dynamic occlusion? Now, dynamic occlusion refers to occlusal contacts that are made when the mandible is moving relative to the maxilla. So the mandible is moved by the muscles of mastications, and the pathways along which the mandible is moving is determined by two terminal factors or two guidance system. We all know about that. One is the condylar guidance and another one is the incisal guidance. So condylar guidance is the posterior guidance system, and it is provided by the temporomandibular joint. And as the head of the condyle moves downward and forwards as the patient is opening the jaw, that is, the condyle is translating. So this guidance system or guidance pathway is determined by the intra-articular disc and along the position of how the angle of the glenoid fossa is. So because of this is in a joint capsule. This is the entire thing in a joint capsule. This is the intra-articular disc over this, and this is the slope of the articular eminence. So whatever is the angle of the slope of the articular eminence, that is along that path only the head of the condyle is going to move downwards. So it is kind of a fixed factor which we cannot, a dentist cannot alter that. So that is the condylar guidance, and it is the posterior guidance system. Now the anterior guidance system, which is away from the temporomandibular joint, is the incisal guidance or the anterior guidance. So usually in ideal occlusion, if we say that anterior guidance or incisal guidance is actually more relevant, and we can control that in a better way because it is away from the temporomandibular joint, and also we can provide an occlusion which is more suited to the patient, which has less harmful effect on the general occlusion of the patient. So anterior guidance, we can see when the patient makes a protrusive movement, like when the patient is asked to make a forward movement and asked to make edge-to-edge contact between the teeth, then all the posterior teeth are out of occlusion. Only the incisal teeth are in contact. So this is actually protecting the posterior occlusion. And in this anterior guidance, if we see, there are various schemes of occlusion schemes are there, like canine guidance is there. So when the patient is moving in lateral excursion, or when the patient is moving in laterally, then only the canine tip is making a contact with the maxillary canine. So that is and actually guiding the mandible in the lateral movement or lateral excursions. So actually protecting both the anterior and the posterior teeth. Similarly, if we see the group function is when the patient is making a lateral movement, then there are contacts only on the working side of the mandible, and there is no contact on the balancing side or the non-working side. So that is the group function. And next is the balanced occlusion, where you have simultaneous contact of all the teeth in centric and eccentric movements. So this is more of an ideal situation in a complete denture case rather than in a dentulous patients. So in dentulous patients, majority of the time canine guidance or mutually protected occlusion or group function is more relevant. So what should be the ideal situation? The ideal situation would be that there should be freedom of contact, that there should be, as the mandible moves slightly forward from centric relation to centric occlusion, it should be providing slight gap, and it should move in the same sagittal and horizontal plane. That is, it should provide freedom in centric, and also when the mandible moves forward, say in the protrusion, then there should be posterior disocclusion. That is to protect the posterior teeth. So whenever a patient comes to us, it is very important to examine the occlusion, the bite of the patient. That is very important, and we should have all pre-treatment examination and records, photographs, the diagnostic models. All these should be there in order to study the occlusion properly and then determine what type of treatment we are going to take up. Now, there are two approaches when we talk about occlusion. One is the conformative approach, and another one is the reorganized approach. Now, what is conformative approach? Conformative approach is when we are planning our treatment so that we are taking the pre-treatment occlusion. That is, we are not altering the occlusion of the patient, and we are preserving the same occlusion as it was before the treatment. That is known as the conformative approach. And when we are changing the occlusion of the patient, say for example, we are increasing the vertical height of the patient, then that is, we are altering the occlusion height, then it is called as the reorganized approach. So these are two types of approaches on base of which we can do treatment for a patient. Another factor which we have to keep in mind is the parafunctional habits. If the patient is having a parafunctional habits, that means there is excess of occlusal load on the teeth and the tissues. So we need to see how we can reduce that and how we can have an occlusion in such type of patients. So the factors which will basically determine what to do in an occlusion, what type of occlusion we should go, or what type of approach we should take up, is basically the resistance of the tissues or whatever restorative material we are taking, depending on what type of load it is subjected to. Say the magnitude of force, how much is the patient biting, or how often the patient is biting, the frequency of the force, the direction of the force, whether the patient is biting, that bite is more vertical, or you have that patient is having tendency of more of lateral force which is applied onto the particular teeth, and the number of contacts which are transmitting the force. That is also another very relevant factor which determines what type of occlusion will be suitable for a particular patient. So with this we come to end of our presentation. Thank you for watching the video. Please like, share and subscribe, and if you have any questions, you can just put it up in the box and I will answer that. Thank you.